Hi, everyone. This is Nina Collins. I'm the Chief Creative Officer at Revel, and we're here today for our weekly podcast recording. Raging Gracefully is the name of our podcast. And we're here today. Today's episode is sponsored by our partners at Alloy. Alloy is a really great telemed company for women in menopause. They prescribe, they have doctors you can talk to, they do a lot of content. The founders are two women in our demographic in their 50s, Monica and Anne, who were fabulous, and we're big fans of Alloy. I, in fact, also have been getting estrogen cream for vaginal dryness from Alloy. So I think they're terrific. And today we're in conversation with Dr. Corinne Menn, who is one of their advisors. And I'm going to briefly read her bio. Dr. Corinne Menn is a board certified OBGYN and NAMS certified menopause practitioner. If you don't know what NAMS is, it's the National American Menopause Society, and it's a great resource for menopause stuff. And you can go on their website and find a doctor. They're really the expert in the field. So it's a big deal that she's NAMS certified. She has over 20 years experience. She has a special interest in menopause management and female cancer survivorship. She had cancer when she was very young. She had breast cancer in her 20s. She's multi-state licensed and practices exclusively through telehealth now. So she no longer sees patients in person. She did for a long time. And now after COVID, a lot of doctors are doing this. They're turning to practices that are purely telehealth, which is great. And she's recently joined Alloy as a medical advisor and a prescribing doctor on their platform. She's an active contributor and longtime volunteer with the Young Survival Coalition, serving on their council of advisors. So I'd love to start the conversation, Dr. Menn, by talking to you a little bit about your personal experience. You told me you have two children, one in college, one in high school. So I'm guessing you're roughly my age, roughly around late 40s, early 50s.
Yeah, so I'm actually going to be 50 on December 3rd. So my birthday's coming up. So I love to share my personal experience going through breast cancer as well as menopause, not once, but 3 times. I'll explain that because I feel like my story highlights a lot of the things that, women, are dealing with. And, it's really informed how I take care of women. And, it really kind of changed my career path.
Yeah, so, when you're a patient, a really serious patient, a hardcore patient, it affects how you doctor for sure.
100%. And it's, I always say breast cancer is the gift that keeps on giving and giving and giving. I say that sarcastically because there's a lot of gifts it keeps on giving that I would like to return. But there's tons of silver linings that I got from my breast cancer experience. So, to tell my whole story would take way too long and probably need a bottle of wine. So I'll just give you the little podcast nutshell, which is basically in 2001, when I was 28 years old, newly married and a second year OBGYN resident, I felt a small lump. And right around the same time, my mom suddenly died of ovarian cancer. That's another long story.
Oh,
so after dealing with her death and burying her, this was, the lump was there for about 2 months. I was like, okay, I better go get this checked out for myself. And, I was too busy being a doctor to take care of myself as a patient. But I finally was prompted to, all right, let's go get this checked out. And right before the holidays in 2001, I was shockingly diagnosed with stage 2, pretty aggressive, invasive breast cancer. So to make a long story short, I wound up having bilateral mastectomy, 6 months of chemotherapy, and then went on tamoxifen therapy. And it was, very difficult, but I was able to, work during most of the time. And, now I'm coming up on my 22-year anniversary of being a young breast cancer survivor. But because of my diagnosis and because of my treatment, and then subsequently finding out that I carried the BRCA2 gene.
I was going to ask, yeah. So let's just, first of all, I'm very sorry your mom died of ovarian cancer. And my mom died of breast cancer when I was 19. So, and I've had the BRCA test a few times, negative, but I relate to a lot of this. I'm so sorry you went through this. Do you have siblings? I mean, that must have been horrible.
Yeah, I have siblings, and initially my genetic testing was negative. This was in 2001, and things have changed a lot genetic testing wise. And really 2001 was a different landscape. People, doctors really weren't as aware of genetic mutations and the impact. And they didn't really know how to deal with young breast cancer patients on many levels, especially with menopause, which, we'll talk certainly more about today. So yeah, it wasn't until, so I was initially tested negative, but because of my knowledge as an OBGYN, all along the way, I made decisions that I treated myself like I was positive, because I just knew something wasn't right with my genes. My mom was 54 when
your mom had ovarian cancer. You get breast cancer
28. So it was like big, so the negative genetic test was not really comforting to me. So I wound up choosing to do the bilateral mastectomy. And then a number of years later, after breast cancer, being fortunate enough to be able to get pregnant still, and I was able to have, one child biologically. Then we decided to adopt our second child so that I could stay on my tamoxifen. I found out from a long lost cousin who was randomly tested and she was like, "Oh, Corinne, I'm BRCA2 positive." I'm like, "Well, that's weird. You don't have cancer. I had cancer."
Oh, God.
So I put my oncologist up and said, "Hey, let's retest me."
Yeah.
And the test, the standard.
The test had really changed. So just for our listeners, everyone should know this. It's really I also was initially tested in 2006 and it was negative. And then I don't know, maybe 3 or 4 years ago, I had a flat precancerous polyp in a colonoscopy. And they said, let's test you again, because the genetic testing has changed so much. And they wanted to know if I had BRCA. So I was tested again a few years ago, which was also negative, but it is one of these things that's constantly improving and changing. So
it's such an important point. And I think, for me, the only reason I was retested was because this cousin had an astute primary care doctor who just took a really solid family history and said, "Hey, you should be tested." But we hadn't been in contact, me and this cousin. So subsequently, I went back, was retested. And before 2012, this is an important point for your listeners. Before 2012, the standard of care with BRCA1 and 2 testing was that it did not include the large rearrangement of the gene, which is commonly called the BART sequence. Okay. So after 2012, 2013, the insurance companies started to include that coverage to look at that part of the gene. And sure enough, that's where my mutation was. It was rearrangement. So, it had, at that point, I had already taken my ovaries out. I had already had a bilateral mastectomy. So for me personally, I was
question.
Okay.
When did you take your ovaries out in relation to when you had your mastectomy?
So not till much later. So I had, the mastectomy, went through chemotherapy, went through menopause temporarily from the chemotherapy, which was terrible and nobody addressed it. Then periods returned, went on tamoxifen, was fine, had a baby, went off tamoxifen, got pregnant, had a baby. When I went back on tamoxifen, the oncologists were like, "Hey, let's put you on Lupron to lower your estrogen levels more." I was like, "Okay, great." Not great. Went through menopause a second time with Lupron, which can be a real beast. So did that for about a year or so. And I was like, yeah, I'm done with this. Decided, okay, I'm going to adopt our second child. So we did that. So at this point, I'm roughly, I think, 33. And after we completed the adoption of Lucia, I decided to just go in and have my ovaries taken out because I knew I wasn't going to have any more babies. So that was, I think I was about 34 then. So that was third time with surgical menopause, which really plummets you and was really extreme.
Wait, I have so many questions. This is such a fascinating story, and I so appreciate you sharing it with us. I mean, one of my questions, one of it is, how did your marriage survive? Because this just sounds like a lot. And I'm curious about your adoption, but I guess that's for a different story. What were your worst menopause symptoms? So each time, was it the same experience or was it different?
I think it was different each time. I'd say the first time I didn't really know what was what, because I was one, dealing with chemotherapy, which is rough. Two, I was incredibly depressed, stressed, and anxious because of this new breast cancer diagnosis.
And also, mom had just died. I mean, for me, after my mom died, I spent 10 years complete anxious wreck, thinking I was going to die, my brother was going to die. Like, I don't know if you had emotional.
Yeah, I didn't have any time to even process it because she died in November, and 6 weeks later, I was diagnosed with breast cancer. And remember, I was 28, just married, and an OBGYN resident. So what was I spending my days doing? Delivering babies, which is what I desperately wanted for myself. All my friends were starting to get pregnant, and I was so excited about, and all of a sudden, oh my God, I didn't know if I was ever going to have a baby.
Yeah.
And then when I wasn't on the labor and delivery floor, I was on the GYN service, which the hospital I worked at, we did a lot of ovarian cancer and very complicated pelvic cases. So then I was in the OR, doing ovarian cancer, cases, which was very traumatic for me because my mom had just died of ovarian cancer. And then I feared I was going to get ovarian cancer.
Yeah.
Plus just add on the crazy work hours of being a resident.
Oh, this sounds so hard. What hospital?
Yeah, it was a little traumatic.
Yeah. Which hospital? Just because I'm from New York.
So I spent half my time at Westchester Medical Center, which is, it's like a tertiary care center. We get a lot of referrals from like upstate, down to Westchester. So we saw a lot of complicated OB and GYN cases. And then the other half of the time I was at Metropolitan Hospital in Manhattan, which was a very different atmosphere, but a very busy labor and delivery with a very different patient population. So I saw a ton of variety. It was very stressful. When you asked me about my marriage, one of the reasons why I think I was able to get through it is because I truly married my best friend. I was super lucky. I met him when I was a freshman at George Washington University, and we've been together ever since. And so he was really incredibly supportive and solid. And, unfortunately, breast cancer and early menopause can really do major damage on a relationship, especially when you get into sexual intimacy and relationship issues and fertility concerns.
You certainly have fake breasts and you have to deal with that. I mean, I have a lot of friends who have done that's a lot. But, did you have a good father also? Has your father been supportive and helpful through all this?
Yes. So my parents had been divorced at the time when my mom passed away, but my dad and my stepmother lived close by and they were extremely supportive. And I have a brother and two very much younger half siblings. And so my family was incredibly supportive. My brother subsequently tested positive for the BRCA2 gene, after I was retested. And
wow.
So important because he has a daughter who's now in high school. I have one biological daughter, and actually this Thanksgiving, when she comes home for break, she's having genetic counseling and she's going to be tested. So, now it's time for my 18-year-old to see if she carries the gene, because generally the guidance is you should generally kind of roughly test about 10 years prior to the youngest affected family member. And I was 28. So, it's time to get her, empowered, and, we'll take
get
care
her
of
on the road. Right. Actually, I have 3 daughters, 4 children. And one of my 24-year-old twins just wrote to me and said, how old was your mom when my mother was 37 when she first had cancer. And so even for her granddaughter, who she never knew, they're suggesting she start getting testing 10 years before the date of her grandmother's first diagnosis. So
absolutely, because there's genetic things that we haven't even discovered yet. And then the other thing for your listeners is not only if they were ever tested before 2012 for the BRCA2 gene, or if their family members were, they just can't assume that test is still, they do need updates, not only for BRCA, which I know that there's a lot more out there than just the BRCA1 and 2 gene. There's tons of other genes that we have now identified, PALB2, COX inhibitors. There's lots of, other Lynch syndrome. There's other things that, women and men should, consider, inquiring about with their doctors.
So when your brother was tested positive, how did that affect was there anything in particular that he's doing? I guess he's being more vigilant about colonoscopies.
Yes. Well, there's a bunch of things, men can and do get breast cancer, and men who carry the BRCA1 and 2 gene certainly are a much higher risk. They're also at a higher risk for prostate cancer and skin cancer, as well as pancreatic cancer. So for him, he's doing, regular skin checks. He got his colonoscopies earlier, he does self breast exams, and, has a clinical breast exam when he sees his internist. And so that's super important for him. And then obviously for his children.
So let's talk about your menopause symptoms. Like, I'm curious how, now you've been in menopause on and off for 25 years almost or something, or 20 years. So what have been your worst symptoms? How do you manage it? How do you deal with HRT? How do you feel about HRT? Let's talk about all of that.
Okay. So in terms of how the symptoms were different, so I'd say during chemotherapy, when I went through kind of chemotoxic menopause from the chemotherapy temporarily like shutting down my ovaries, I'd say my worst symptoms then, I could deal with the hot flashes, but the worst symptoms were certainly the sleep disturbances.
Yeah, it's the worst.
Yeah. And then the mood changes. And I think it was complex because I had lots else going on. And so it was all kind of a blur and no one really was treating me for it. Looking back, I should have been right from the get-go advised that I should be on an SSRI to help with the stress, the mood changes and the sleep. And unfortunately, nobody offered it to me. And, at that time, no one would have even thought.
I have a question just because it's so interesting, right? I mean, we all acknowledge that healthcare in our country is completely screwed up. It's very hard to get good care. But as a doctor, the fact that no one offered this to you and that you didn't think to ask also is so sad. Like it's such a indictment of our system.
100%. And I think part of it was, I think things have improved over the 20 years. So it was 20 years ago. I think people have tunnel vision, just patients and doctors when you have breast cancer diagnosis. And then when you take that and throw me as I was, 28, everybody, it doesn't even know what to do with you. I was like this crazy thing. And everyone's like, oh my God, what do we do? Everyone was scared to treat me outside of just like, taking care of my cancer. No one was thinking about any of the collateral damage. And as a doctor, I was still very young. I was only a second-year resident. I didn't know enough.
You were a baby. Yeah.
I was a baby and no one trains you in residency for menopause, treatment. And certainly no one knew what to do with premature menopause. So then when I had my symptoms, my second menopause, when I had, had my baby and I went back on tamoxifen, which tamoxifen itself did not cause me to have any menopausal symptoms because I was still getting a regular menstrual period. Tamoxifen doesn't put you into menopause. But they added Lupron on top of the tamoxifen, and Lupron shut down my ovaries. So that time I'd say my symptoms were across the board much more severe. I had terrible sleep, terrible insomnia, what I now know to be anxiety. At the time, I didn't even understand, but like I just felt like a tightness in my chest during the day, or a hot flash would come along with the feelings of, I say, being uncomfortable in your own skin. And I honestly think that's where the term hot and bothered comes from, which is a really misogynist term. But I felt hot and bothered. I was bothered, so that was really hard. But also that's when I think I had more sexual side effects, like decreased libido from definitely the stress and lack of sleep, but also a lot of vaginal dryness. And at that time, once again, my oncologist, who I love, really didn't address those needs. It was, my GYN was afraid of me because I had had breast cancer. So they didn't know what to do with me. And that's when I started to self-educate and realize I needed to like learn more, and read a lot, and finally found the North American Menopause Society and got, certified. So, but even then I, certainly wasn't using any estrogen products at the time. And it wasn't until like months into the Lupron that an astute nurse practitioner who was working with my oncologist was like, Corinne, you need a little SSRI. Let's at least give you that so that maybe you could help a little bit with the anxious feelings. It may help the hot flashes and sleep. And, thank God she put me on that.
Someone in the audience, sorry to interrupt, but someone in the audience asked what SSRI is. So just in case you
know. Oh, sure. SSRI is, a selective serotonin reuptake inhibitor. So it's basically like Prozac, Effexor, Paxil, Zoloft, Lexapro, which, can be quite helpful for treating some of the mood changes, and it can help with sleep and stuff in menopause. Certainly not as well as HRT, but again, at the time, remember, breast cancer survivor. So at the time, no one was going to be offering me any hormone replacement therapy, although I think there's a lot to unpack there, and we can talk a little bit more about that too. So then when I had my ovaries removed, I had had a little break between the Lupron and the ovaries being removed. So I was like, I'm sick of this Lupron. I took a little break of that. So then I started to feel a little bit better, still stayed on the tamoxifen. And then when I had my ovaries removed, now that was just like, that was the worst, because
it was the worst
overnight. And again, and looking back, I really should have been more proactive, but You know what? I think I was just busy trying to be a mom and a doctor and kind of feeling.
Yeah, and people really don't or didn't talk about menopause. And as you said, really didn't know what to do with you. It was really unusual. I mean, things have changed, right, in the last 10, 20 years about how we talk about the emotional side effects of disease. And, we're a little more open, I think, about death and dying in general, and mental illness in general. But, oh, you poor thing. This is just a brutal story.
The lesson learned from that surgical menopause. And, I'm grateful to have gone through it. One, because I think it was important for me to obviously have my ovaries removed to protect myself from ovarian cancer. But I learned exactly what all of my patients were going through, because literally in 2 months, I easily gained 15 pounds, easily. All of a sudden I had the menopausal pot belly and just like thickness in the middle. And guess what? My cholesterol went up and my thyroid crapped out, and my sleep was terrible, and the vaginal dryness became severe. And so it was around that time that I was getting involved with the North American Menopause Society. So I was definitely starting to be more, knowledgeable. And that's when I started vaginal estrogen, which is a huge game changer. And I knew back then that it was very safe, although the recommendations were still very very touchy when it comes to anybody with a history of breast cancer. Luckily, we know now that really virtually all women, it's very safe and highly effective to take vaginal estrogen. So,
although I do wonder, I have to say, I know it's really safe and everyone should do it if they need it for dryness, but when they say that vaginal estrogen doesn't cross the barrier, the skin barrier, is that completely true? Like, I feel like when I've been on vaginal estrogen, I feel it sometimes. My breasts get a little heavier. Is that just my imagination?
So, no, I don't think it's your imagination. So I think studies, what
you're freezing a little bit.
Treatment, your systemic estradiol level is, it is not significant. Now, there can be, with the vaginal estrogen cream, sometimes when you first use it, you can have a little uptick at first, but then when you kind of look at, if you follow those patients over 12 weeks, once they start, right back down. And when I say an uptick, I mean tiny, a little bit. Now, with the more, some people use a little bit less. It's not dangerous if you are, if you have a little bit of systemic exposure. I think for breast cancer survivors, we might be a little extra cautious and just make sure they're using like a lower dose and, using appropriately. And I also think there are some just differences. Some people just absorb things and their tissue receptors are more sensitive.
Right,
so if I have a woman who tells me like, I feel a little different, a little breast tenderness, I believe them, of course. We're all a little different. And if that's something that bothers them or we're concerned about it for every reason, we can just adjust the dose.
Corinne, our reception is going out a little bit. Let's try turning it back on and let's try and continue this way. And I've just moved slightly, so hopefully we'll be better.
Okay, and let me know. I can just turn it off again.
So you got your ovaries out and you got on an antidepressant and a little bit of vaginal estrogen. Did you ever reach a place where you were on full-on hormone replacement therapy?
I have not. I did really well for a long time I wound up using Effexor along with the vaginal estrogen. And I did that really for many, many years. And recently, I've decided to take a little break of the Effexor just to kind of see it. It took me a little bit of time to come off it. Warning, Effexor can be highly effective for hot flash relief and night sweats and, insomnia and stuff.
And depression. Effexor is often diagnosed for depression, isn't it?
Yeah. So Effexor is, it's one of the, it's a SNRI. It works very similar to Prozac and, those medications. It's one of the antidepressants that has a lot of data, in terms of helping with hot flashes, particularly in breast cancer survivors or, women who can or decide not to take HRT. It's not approved,
I didn't know that.
Yeah, it's not. So paroxetine is the only one that's FDA approved for that. But if you're on tamoxifen, you cannot take paroxetine, okay? Because it interferes with the metabolism of tamoxifen. So paroxetine is not an option for me being on, when I was on tamoxifen. So that's why I chose Effexor, because we've got the most data on that. Effexor can be great. I will tell your listeners and anybody out there, Effexor can be, it's not easy to come off of Effexor. It took me a long time, and you have to do it properly and titrate it down. And sometimes I wound up using a little Prozac with the Effexor to finally get myself off of it, because you can have.
Can I ask you how long it took? Because I hear this, and I have a family member who's on Effexor, and it's been really kind of brutal. And Effexor is hard. Like if you miss a dose, you can get really sick.
Yes.
It's a pretty intense drug. How long did it take you to get off of it?
So I kind of I read up on kind of the best methods, and just from feedback from my patients who I've been like, oh, you can stop your Effexor, and then they call me and tell me they feel terrible. I've learned so that it took me a few weeks. What you need to do is you need to prescribe it with a little bit of Prozac, because Prozac has a long half-life, but it also doesn't have that same kind of tolerance that happens with Effexor and the kind of rebound effects. So basically, I started Prozac, very low dose, along with my Effexor. And then after about a week, I cut my Effexor dose in half. Did that for another week. Then I started taking my Effexor like every other day for a week. And then I just stopped, continued on the Prozac for another 2 weeks. And then I just stopped it all.
Interesting.
So, that's helpful. So I've just done that recently, because I've been on it for a while, and I just wanted to see how I felt hot flash wise. Yeah, they're back.
Yeah, I have to say, I've been thinking, so I've been on and off Prozac most of my adult life for kind of depression and anxiety. And lately there have been a lot of studies about how everyone is overprescribed on antidepressants, and they don't really do anything, and people should get off them. So I've just decided to take my Prozac out of my rotation, and I'll see how I feel. I mean, in the past, in my 30s, I would go off Prozac and I would get kind of depressed, and I would go back on. This time I actually feel good. I'm no longer in therapy. Like I'm in a good emotional state. I really went back on it because of hot flashes before I went on HRT. It's so confusing. Getting older is like no joke. All these figuring out all these things. So anyway, I'll see how I feel being off Prozac. So are you worried about your anxiety? You think you'll be okay without it?
So, I think I don't have an underlying anxiety disorder. I do think the feelings of anxiety come from the hot flashes, the insomnia. I will tell you, this is like an experiment in real time. I will tell you, I just did this, and I'm, already feeling, nighttime. I'm not sleeping as well. It's only been a couple of weeks. And I do feel those more anxious feelings. I think it's important for everyone to understand if an SSRI is working for you and it's helping your mental health and you feel better, you should not be afraid to stay on it for the long term, because these are all, risks and benefits and quality of life. And if you're not having any bad side effects, then fine. For me, I chose to take a break from it just to see. I'd been on it for a while. We know that there's a really real association with sexual dysfunction and a decrease in sexual desire, and as well as, the ability to orgasm and to feel stimulated when you're taking any of these centrally acting medications, any of these antidepressants. So, I was kind of curious to see how I would feel in terms of that as well.
Yeah,
so that's
same here. Twins.
So,
I feel the same.
But I always caution people, like, don't, I never want someone who really has improved with depression and generalized anxiety to feel like some need to go off these medications, but you should talk to your doctor. Sometimes you can tweak doses, change medications. There's other options. And now in terms of hormone replacement therapy, I'm really at this point now where I'm going to be working with my oncologist and kind of discussing with him, kind of the newest understanding of hormone replacement therapy in breast cancer survivors. There's incredible information. If anyone hasn't read Dr. Bluming's book, Estrogen Matters, it needs to be like a must read for any woman who wants to understand estrogen in general and really understand how we got to this state in our country of so much fear around breast cancer and estrogen. So he's an incredible, very prominent oncologist and one of the most thoughtful physicians I've ever spoken to. He's actually really become a mentor to me. And it's just an incredible book. And so after reading that and kind of diving in a little bit more in the research, on my own, I think I'm ready at this point of being 20 years post-diagnosis to discuss with my oncologist an individual kind of approach to considering maybe low dose HRT. Everything in life is a risk benefit determination. And I think for all women, no matter what you're going through, you have to say to yourself, what am I going through with my health? What are my, solutions that are evidence-based and science-based? And what's the benefits of them? What's the risks of them? And what's the risks of not doing that? So everyone, when we talk about risks of hormone replacement therapy, people are concerned about, well, what's the risks of it? Okay. And it's an important question, but I think it's equally important for an otherwise healthy person who's symptomatic to really ask themselves, what's the risk of me not treating my menopausal symptoms? Yeah. Well, that list is quite long.
Yeah, when you can't sleep and you're up all night having hot flashes and feeling anxious, it takes a toll on your life for sure. And I mean, I hear you about you want your sexual response to be good. I mean, that's a whole other issue. Like I'm just starting Interosa.
Love that, yes.
Which I've never tried before, so I'll see how that goes.
Yeah.
And Interosa, for anyone who's listening, it's a DHEA vaginal suppository. So I guess doesn't DHEA convert to testosterone?
To estrogen and testosterone. So DHEA inserts are really interesting. They're another great option for treating the vaginal symptoms of menopause. Basically, DHA gets absorbed into the cells in the genital area, and it gets converted to estrogen within the cell. Okay, so there's no systemic increased risk, level. Your levels of estrogen aren't going to be raised. It really works very similar to other vaginal estrogen products. It was a smart move for the pharmaceutical company because they don't have the black box nonsense estrogen label that gets, placed on every single vaginal estrogen, product out there. So it could be more reassuring for some women. They shouldn't worry regardless, because that's a whole.
It is okay. Yeah. What do you feel about testosterone for women?
Yeah. So testosterone, a bunch of things. So testosterone, unfortunately, we don't have an FDA approved product for women in the United States. It is available in other countries, but not in the United States. And, there are some very good data and guidelines out there that show that, for women with hypoactive sexual desire disorder, okay, where like low desire and, problems with arousal, that for about 50% of women who try transdermal testosterone, they'll have an improvement in it. And there are safe regimens on how to prescribe it. We generally, when we talk about hormone replacement therapy, and this includes using testosterone, we tend not to like compounded medications, because a compounded medication, is not, standardized. It's not FDA approved. That being said, there is a place in medicine for compounded products for sure. But when we have FDA approved products, we should always try to use those. But unfortunately, we don't for women. So women have two options for testosterone: is either to find a trusted compounding pharmacy and have a menopause literate physician prescribe it properly for them, or you can use male products, but used in much, much lower doses. But the good thing is I'll give you the resource. There's a great statement by the International Society for Sexual Health and Wellness that clearly outlines exactly how these testosterone products should be prescribed, and also understanding the evidence. So I'd say it's not a game changer for all women, but it can be helpful if you've tried other things and you're still having problems with your sexual response.
Interesting. That's really helpful. Yeah. I mean, as you know, one of the biggest problems women our age have is just finding good medical care, which is why it's so great that places like Alloy exist, and that doctors like you are just starting to do telemed business, because so much of it is conversation and trying to figure out what the right solution is. And I've had mediocre care since my gynecologist retired a few years ago, and just found someone this week who actually spoke to me like you're doing for an hour. And so now I'm going to try Interosa for a few months. And if that doesn't work, we're going to try a little bit of testosterone, and I'm on HRT. So, but talking to you just makes me, I mean, it just accentuates for everyone how complicated all this is, right? And how much you need someone who's going to listen to your own story and pull out the pieces. So what's your work like with Alloy? What are you doing at Alloy?
So, I'm working with Alloy in kind of two capacities. One, I'm a prescribing physician on their actual platform, so, and by working with Alloy, it's prompted me to get licensed in a lot more states so that I can, see more of Alloy's patients. So that's great. So I'm getting to do that menopause, care, through the platform. But then on a separate, kind of job, I'm, helping as a medical advisor with really, with my biggest responsibilities being, doing more patient education, doing social media for them, kind of really patient education, social media, which is so important because women just need a lot of the
we need a lot of information. Yeah. Like I mean, what you and I have discussed, I worry a little, we've probably gone over a lot of technical details fast. We've talked about a lot of stuff, and you're right. There's just so much education, both basic and more advanced, that we all need. And particularly, I think, in this environment where it's harder and harder to get doctor's appointments and just good care. I was talking to someone this morning who said he feels like more people seem to have insurance these days, but no one has like just one doctor who actually listens to them. Like all these medical, everyone's owned by corporations. It's just increasingly difficult.
Yeah. So, I think a couple of things, people ask me, well, why are there so many doctors who don't understand menopause? And why are so many doctors still hanging on to myths and fears around hormone replacement therapy? Yeah. And I always explain to patients, like, understand where your doctor's coming from. And I can tell you that, doctors my age, and a little bit older and certainly a little bit younger than me, came through training during the era of the WHI, the Women's Health Initiative, which had terrible messaging, misinterpreted results, and the media ran with it and just spread a lot of fear and misinformation. Well, that not only affected patients, it affected doctors, because literally overnight they got phone calls from their patients, and they were scared. And so the doctors were like, I'm not dealing with this. So there was a lot of trauma in medicine for that. That's one. OBGYNs are have the highest malpractice, costs, and are the most sued doctors. So unfortunately in our country, OBGYNs practice in a very litigious environment. And so in general, OBGYNs are afraid to, veer outside of anything that doesn't seem quote unquote safe, and like they just take the middle road, And then the third problem is the corporatization of medicine. I saw it in my own professional experience where I was part of a group. They sold it to the hospital. I didn't want to work for a hospital. I left. I started my own thing. But most doctors don't do that. They stay as part of big corporate medicine, which makes it really hard to spend time. And it also makes it really hard sometimes to be progressive and to move along, because you get into this very dogmatic kind of institutionalized approach to medicine. So those are the three reasons why your doctor cares about you. And trust me, they're good doctors, but those three things have prevented them from for really leveling up their knowledge base, and also just time. They're expected to see a patient every 10 minutes. They do not have the time to go to conferences and do this and stay on top of things, unfortunately.
So that's a great answer. And then a harder question is, what's the solution? What should your average person do about getting the best care?
Well, I think the most important thing is, I know it can be overwhelming, all this stuff about menopause and midlife women's health, but the reality is, be reassured, we have extremely clear evidence-based guidelines. Go to the North American Menopause Society. I feel like that's the best source of kind of general information for patients. Find, a few people, providers and doctors online that are discussing this, follow them, but make sure you're following people who are following evidence-based medicine, because right now, this space of menopause is blowing up and there's a ton of fluff. There's a ton of BS out there.
Mm-hmm.
And there's a lot of people trying to profit on women's fears about hormone replacement therapy and estrogen. So, just like anything, you have to be a smart consumer.
Yeah.
Of
and an advocate for yourself. And you have to push when you're not getting the answers that you need.
And I will tell you, most doctors, if you go to them with a very clear list of, here are my symptoms, here are my problems. I went to the North American Menopause Society. Here's their 2022 guidelines on HRT. It's really clear. It's not many pages. Be like, this is what I really want. And if they are not willing, and they say they don't believe in it, then they don't believe in science. Then you need to find somebody else.
Yeah, absolutely.
Period. But most of the time, they'll help you out.
Right. You've been so fantastic. I want to get to one last question from the audience. Someone in the audience says, I was told that testosterone breaks down into estrogen, so it's a hard no for estrogen positive breast cancer. Can you speak to that?
Yes. So I think that in general, that is the sentiment, and that's the guidelines out there. But what I will say is absolutely right. So testosterone and estrogen, all these sex hormones can get converted to each other by your fat cells in your body. It happens, right? Nothing in medicine should be hard no's when you're talking about dealing with an individual patient. So I would say to that patient that, I think you need to, have a discussion with your doctor about why you might want to try that. If you're having sexual dysfunction, what are the alternatives to testosterone, and what are the risks benefit analysis? And I think that saying no and denying access like a gatekeeper is not what a doctor's job is. It should be to provide the risk and benefits and let the patient have a voice in making a decision about what she wants.
Yeah. Fantastic. I hope that helps to Jamie, our listener. Well, you've just been great, Corinne. I really appreciate this conversation. So knowledgeable, so open. What an incredible story. So important to share it. And just thank you. And I look forward to seeing the work that you do on Alloy, and thank you.
Yeah, you're welcome. And anybody is welcome to, they can send me a message, any of the listeners, if they have a follow-up question or, need some resources. So, I'll give you my
How can people find you, and how should they follow you?
So they should follow two things. Follow me at, of course, myalloy.com, my Alloy on Instagram. And then my personal Instagram is Dr. Menn OBGYN. So DRMENN OBGYN. So mostly on Instagram, sometimes on TikTok. And then my website is just drmenn.com.
Okay.
So.
All right. drmenn.com. All right. You've been fabulous. Thank you. I hope you have a great day, and good luck with everything.
Yeah, I really enjoyed talking to you. Take care.
Take care. Bye-bye.